Good afternoon, everyone. I am Rahul Gosain.
And I'm Rohit Gosain.
And we are Oncology Brothers. Today, we would like to welcome Dr. Hillengass, a professor of oncology and a practicing hematologist at the Roswell Comprehensive Cancer Center, where he's also the chair of the myeloma program. In our discussion, we hope Dr. Hillengass will walk us through his approach to treating multiple myeloma. We have a lot to cover. So without further ado, let us welcome Dr. Hillengass.
Hi, thank you so much for having me.
Thank you, Dr. Hillengass. We are hoping that we can use this algorithm to reiterate the current standard of care practice for multiple myeloma in our community setting. Here's the algorithm, and stage is all yours.
Thank you so much for the kind introduction, and thank you for giving me the chance to talk about myeloma. As both of you know, it's difficult to stop me talking about myeloma, so I'm really happy to share some experiences and some kind of life hacks how we can treat our patients best. As you see on the top, the CREB criteria is still very relevant in myeloma because those are the major symptoms that our patients have. To treat patients a bit earlier than and not to wait until they already have symptoms. We have invented or we have established new myeloma defining events, as we call them. One is a plasma cell percentage in the bone marrow, monoclonal plasma cells of more than 60%. And that's one thing that you have to be careful. Very rarely in, for example, patients with liver disease, they can have high plasma cell percentages, but those plasma cells are polyclonal. So to have a myeloma, it has to be more than 10% monoclonal plasma cells, being only kappa or only lambda, which are the two light chains that we have in these plasma cells. The free light chain ratio is the ratio of the serum free light chains. I see a lot of colleagues doing urine free light chains. The test is approved. It's not very reliable, to be honest. So I would rely rather of the serum free light chains. And then if you do imaging, MRI, or even PET-CT, if a patient has more than one focal lesion, which is an accumulation of myeloma cells in the bone marrow, these focal lesions qualify a patient also to get systemic treatment. On the right-hand side, you see that high-risk cytogenetics in the bone marrow, in the myeloma cells in the bone marrow, are relevant markers. Deletion 17p, you know, from other areas, from other cancers. Very relevant is the TP53 tumor suppressor gene is located there. Then there are translocations of the IG, of the heavy chain gene, which is relevant in plasma cells. Obviously, it's the 414 and the 1416. And then something that's called a gain of 1q. 1q is the chromosome, is one arm of the chromosome 1, and a loss of 1p, which is the other arm of the chromosome 1. And the 1q gain can be reported in fish as a gain of 1q, which is 3 copies of the 1q element, or it can be an amplification, which is more than 3. And it has been shown in certain trials that the amplification is worse than the gain, so more of this 1q seems to be negative for the patients. Coming to the newly diagnosed patient sitting in front of you, what are the questions that we ask ourselves and what are the questions that we ask our patient? And transplant in this regard means autologous stem cell transplant with a high-dose chemotherapy. And in patients who are standard risk, RVD, the lenalidomide, bortezomib, and dexamethasone 4 cycles induction treatment is still considered standard of care. There has been a recent trial, a so-called Griffin trial, comparing that to daratumumab and lenalidomide, bortezomib, dexamethasone, and there was a benefit. Patients went into a deeper remission faster. They have cleaner stem cells that we can use for the autologous stem cell transplant, and also a deeper remission goes along with a better prognosis on the long run. And that's something that we try to achieve with our induction treatment already. If they have high-risk disease, I think lenalidomide, dexamethasone, and bortezomib are not the standard of care anymore. What we recommend is the daratumumab RVD, or replacing the bortezomib with carfilzomib, lenalidomide, dexamethasone. So DARA, RVD, or KRD are for high-risk patients definitely the standard of care. But as you can see, even in standard risk patients, the DARA RVD has shown really good responses. And then the next step is the stem cell collection, where we collect autologous, their own stem cells, so that we can give a high-dose chemotherapy, which then when we give the stem cells after as a transplant, recovers the bone marrow for the patient. And then you can see the next orange box would be a consolidation. As I said, it's really important to achieve a very deep remission in those patients. Best would be a complete remission. Even better would be a minimal residual disease negativity, and I will go into that a little bit further on. But if a patient has not achieved a deep remission after the autologous transplant, a consolidation with a similar treatment that they had before is recommended. And after that, every patient should get a maintenance treatment. Lenalidomide maintenance treatment as compared to no treatment at all or placebo has shown an improvement even of the overall survival, which is in patients with myeloma who live fairly long and have very many treatment lines, which is really impressive to achieve an overall survival benefit. And there was a meta-analysis, several studies taken together all showed maintenance is very important in myeloma and it improves the prognosis. There have been studies using additions to the lenalidomide. One is daratumumab, especially if the patient had the daratumumab before. It seems to be beneficial for them as well if they responded. Or carfilzomib was another trial together with lenalidomide. It's mentioned here for 2 years. What I do in most of my patients, if they have standard risk, I continue them with the lenalidomide right away after the transplant if they're in a good remission. If they have high-risk disease, I usually give them between 1 and 3 years of this combination, either dara-len or carfilzomib-len. And then after that, I switch to lenalidomide alone. So I don't stop after these 2 years, but I continue treatment with just lenalidomide, and most patients tolerate that very well.
Thank you so much for going over this algorithm so comprehensively. Truly appreciate that. Talking about the CRAB criteria, which we were used to before, now we are utilizing Slim CRAB as you went over. So thank you so much for pointing that. For transplant eligible patients, if they have undergone induction regimen and now they want to delay their transplant, do you get the stem cell collected post 3 to 4 cycles once we've documented CR? And how long do you continue on with the induction therapy before the transplant?
Yeah, that's a great question that patients are also asking because they go online and go on a forum and get these ideas. I'm still in my heart a transplanter because I've always been. That's not a really good argument, but you know how we are raised, that oftentimes determines what we decide. I definitely recommend for every patient who is remotely eligible for a stem cell transplant, they should collect their stem cells. The time point is, of course, the deeper the remission, the better. The problem at one point, it becomes a bit more challenging to collect enough stem cells, not so much in the US because we have access to plerixafor, which usually can collect for every patient. So I definitely recommend after 4 cycles, or if you already know the patient doesn't want a transplant, then I would say at best response. If you still see an improvement, then I would collect when they have their best response, for example, a complete remission or at least a very good partial remission. If we know that the patient goes on to transplant and we see, for example, that they plateau with their M spike, then I would definitely collect at that point in time and then go on to the transplant. Because we have to keep in mind, usually when a patient is not responding anymore, we try to change the treatment. A stem cell transplant is part of the initial treatment, but it's also kind of a change of treatment because melphalan is a completely different mechanism of action as compared to these induction treatments. For the duration, if the patient is not getting a transplant, that's a little bit up in the air. Several trials have done either 8 cycles in total and then maintenance. Others have done 12 cycles and then maintenance. I usually tend to be a bit more aggressive if the patient is still not in a deep remission. And I would adjust that if we know they're not in a clinical trial, they don't want a transplant, but they have to collect their cells. I would make it dependent on the patient's preference. I would make it depend. I have patients who say, I don't want a transplant, but I want an optimal treatment. So I would give them a bit more. In a patient who says, I want to be done with this as soon as possible and go to my maintenance, and they're in a good remission, then I think it's okay to stop after 8 or 10 cycles as well.
Thank you for that, Dr. Hillengass. Staying in front line, a common scenario that we run into ends up being a patient with diffuse bone involvement and renal insufficiency. So given that these patients have significant renal impairment, how does your upfront treatment management change? And how do you dose these medications with that renal insufficiency?
Yeah, that's also a very important question. Sometimes what we have done, if the patient is really close to or at dialysis, we have given them the Cybor-D with cyclophosphamide just because we have done that in the past. But lenalidomide is approved for even patients with really significantly impaired renal insufficiency, and I recommend to look into the medication information to see what the adequate dose is. Adjust that to the patient. Very, very rarely the lenalidomide causes worsening of the kidney function. That's not a problem with the bortezomib, and not a problem with the dexamethasone, and not a problem with the daratumumab, and also not with the carfilzomib. So it's only the lenalidomide where we have to have an eye on. But I usually try to bring them on the RVD as soon as possible, or the DARA RVD or the KRD, because the lenalidomide combinations have shown to be better than the Cybor-D, and bringing the patient in a deep remission is the best we can do for them and for their kidneys. And kidney recovery is a very common phenomenon in myeloma. We see that as soon as the patient achieves a deep remission, and the faster the better. I always say time is kidney. We should not elaborate around and wait and try and kind of give them fluids. We should treat them as soon as possible, because that increases their chance to improve their kidney function fast.
Now, going on the same patient, this patient did get, in fact, induction and ended up getting transplant, now has CR. Your management, does it change if it is standard risk versus high risk from consolidation standpoint, or you get them started on maintenance?
I would still give them starting them on maintenance. There is old data showing that a renal insufficiency is a bad prognostic marker, but that's mostly because those patients are not treated very effectively, right? So if we treat them effectively and they achieve a deep remission, I would consider them to be same as every other patient as well. If they remain on dialysis, it's obviously challenging, but it is also possible, because another thing that we should maybe mention briefly, the light chains are elevated in patients with renal insufficiency, right? It's oftentimes confusing. The patients see that they still have elevated light chains, but if both light chains are elevated, it's much more likely to be related to the kidney function than to the actual myeloma. And if the ratio, for example, is normal or only slightly off, that is something that can still be a very deep remission. For the patients who are not considered eligible for a stem cell transplant because they are older or they are frail or have a lot of comorbidities, if they're still fit enough that we feel comfortable, we can give them a milder version of this DARA RVD, especially if they have high-risk disease. If they are standard risk disease and more frail, or fit and standard risk disease, in my experience, daratumumab, lenalidomide, and dexamethasone, based on the MAIA trial, is an excellent treatment which can bring patients in a deep remission. What I would like to mention here is I have patients where colleagues sent them to me and said, I don't dare to treat this patient. Daratumumab alone is a good starting point, because oftentimes, especially elderly patients, they are mostly frail because of their myeloma. Obviously, if they have other comorbidities, that might also be the reason. But I have seen many, many patients who improved significantly in their performance status once the myeloma was controlled. And then you can add the lenalidomide and the dexamethasone, and then you have a really excellent treatment for these patients, even if they're very frail to begin with. So that's one approach that we have done. Dexamethasone alone is another option, or dexamethasone and lenalidomide alone is another option. I would adjust it to the patient and also what the insurance allows us to do, but that's what I try to do in my practice.
You've mentioned this briefly, but I would love to dig a little deeper on this. Would you consider DARA RVD light or DARA RD in otherwise fit patient who has standard risk cytogenetics?
Yeah, absolutely. Do you mean in the setting of renal insufficiency or in the setting of general?
In general patient population.
In general patient, in my experience, again, the really fit and high risk, the fit frail, I try to do DARA RVD, because sometimes, as I mentioned, sometimes the patient becomes transplant eligible, right? If they're in their mid-70s, they still can collect stem cells. That's not, if we see, oh, wow, they do so much better and we would consider transplant, then we can still do that. So either way, bringing them in a deep remission fast, I think, is the most important message. And of course, not harming them with too many side effects. When it comes to relapse, it becomes very, very complicated, unfortunately. The problem is that it depends very much on how the patient responded to their first-line treatment. If we have the feeling or can confirm that they're still not refractory to lenalidomide, which is our bread and butter treatment nowadays, then we could use a combination that includes the lenalidomide. If they are refractory to lenalidomide, then we would choose something else. One rule of thumb is to change as much as we can and as much as we have to. I have done in some patients, and I've seen colleagues doing that as well with some success, to add something to the lenalidomide. You know, those patients who have a very slow progression, go up with their light chains 10 every other month or something like that, where we feel there's still an effect of the lenalidomide. Sometimes I've added something like elotuzumab or ixazomib, which are very well tolerated treatments, and then sometimes we can squeeze out a little bit more benefit for the patients, especially in elderly frail. In the younger or patients who have a very aggressive relapse, I would change out as much as possible. If they come from an IMiD, so lenalidomide, pomalidomide-based background, then I would give them a proteasome inhibitor and an antibody. For example, a very good combination is shown here with the daratumumab, the carfilzomib and the dexamethasone, or the isatuximab and the carfilzomib dexamethasone. Those are excellent drugs that are really bringing the patients back in a deep remission in most of the cases. If they are refractory to a proteasome inhibitor, then I would switch to an antibody and a IMiD, like the pomalidomide or lenalidomide, depending if they are refractory to that or not. So this adjusting to the aggressiveness of the relapse and to the refractoriness, and also, of course, side effects. If they have neuropathy, I would not give them bortezomib or ixazomib anymore. For patients who have had a thromboembolic event, I might use the IMiDs a bit later. That's another thing that I usually do, even if they had a thromboembolic event on a lenalidomide or pomalidomide treatment, I would still consider that if they're in full anticoagulation, I would still feel comfortable giving them a treatment out of this class of drugs. And then thereafter, it's basically a little bit the Wild West. So everything that they have not had yet, and then what they can tolerate, we can basically mix and match. Obviously, CAR T cells are the new kid on the block and are really excellent. We just recently got an approval for a bispecific antibody, same concept, where a double antibody basically brings the T cell to the myeloma cell. It's called teclistamab. Those are treatments that should be, for now, I think just because they're very new, should be done at the center. But everything else, even selinexor with the new recommendations with anti-emesis and also with the once weekly dosing, patients tolerate it much better than they did initially when it was invented. And then good old chemo drugs. Being from Germany, I'm still used to use a lot of chemotherapy. And sometimes my colleagues here smile about it. But in patients who are in good shape and are refractory to everything else, they can have a really good benefit from certain chemotherapeutic drugs.
Covering and diving into the world of relapse refractory, we can see explosion of the treatment options here. We've also seen withdrawal of belantamab very recently. Before we move on, your thoughts on this recent withdrawal by any chance?
Yeah, the combination. So the trials are always challenging, and of course, it was not significantly better. Being a myeloma doctor, I of course cling to every drug that is available. The same story with the melflufen a while ago. So we would not like to lose those drugs, because what we also know that there is a combination possibility, right? You can combine the belantamab mafodotin with pomalidomide, but yeah, obviously it was not better than pomalidomide dexamethasone, and not significantly better. It didn't fulfill the criteria. If you look at the survival curves, they were better for belantamab mafodotin, but then again, it also depends very much on the patient. I hope that we still can keep those drugs at least in combination, because most of them are fairly well tolerated.
Dr. Hillengass, just to bring it back from the community side of things and standard of care, the combination of Blenta is not standard of care right now, correct? This is all more, if anything, anecdotal experience or what you've seen.
Correct. And from phase 1 and phase 2 clinical trials, right? And that's something where I think it's really okay to send a patient to someone like myself who does nothing but myeloma all day long.
Absolutely. And in the same refractory patient population, How prevalent is 1114 translocation, and do you rely on venetoclax in this particular subset?
Yeah, I don't exactly know these IGH translocations are very stable over the course of the disease. So if the patient has that, they usually appear fairly early. But it's definitely worth looking for that, and that's what we do if we run out of options, or if it's likely that the patient has 1114, and even if it was not there initially. That's definitely a very good option. Again, not approved, but very good clinical data. Not good for non-1114 patients, but very good, the venetoclax, especially in combination for patients who have 1114 translocation or a BCL2 over expression.
While we are on this topic where we are focusing treatment and doing this personalized medicine, any experience from selinexor standpoint, we have been very reluctant in community to utilize this therapy based on the side effect profile and limited benefit. Your thoughts on that?
Yeah, so as I said, the side effect profile is more manageable with the newer schedules where you have it once a week in a lower dose, and the company kind of promotes that too, but that's also my experience. If you cover them with really good anti-emetic drugs, it is usually fairly well tolerated. I, again, based on phase 1 and 2 trials, combine it with other drugs, depending on what the patient had before. It is an all-oral drug. So it's an oral drug, and if we, for example, combine it with pomalidomide, we can do an all-oral treatment, which is oftentimes intriguing for patients, especially if they're a little bit more remote. I don't have a certain patient group where I would say selinexor is the option, but I would say it's definitely not my second or third line, even though my approval might allow that earlier. I give it when I run out of options. Oftentimes I give it as a bridging. If a patient is a candidate for a CAR T-cell therapy, I give it as a bridging until we can do that, because it's not very T-cell toxic, which is also something to keep in mind. If we consider a patient for a CAR T candidate, we should not ruin his T-cell repertoire too early with cyclophosphamide or bendamustine. But the selinexor might be beneficial in this area.
Certainly, just adding to that what you just mentioned as a bridging approach, along with selinexor or any other medications or any therapies that you utilize for bridging these patients.
Yeah, unfortunately, bridging is always challenging, because when we are at that point, at the moment still, when we are at that point, oftentimes we only have chemotherapy left, and almost all chemotherapy is T-cell toxic, so that's not great. We try selinexor. I would, for example, not try now it's off the market anyway, but belantamab mafodotin, because it has the same target as the CAR T-cells. We have done in patients when it's very aggressive disease, we have done VDT PACE, which is obviously also not very mild, but sometimes it brings the patient into remission, and then when they recover, that's an option. What we have also done, we have given them a lower dose or intermediate dose of melphalan, and then if they have frozen stem cells from earlier, we give them their stem cells back, which then allows them to rebuild the immune system, which then has T cells again. So there are not really great bridging therapies for that right now. If the patient is not refractory to daratumumab, carfilzomib, those are obviously preferred options, but most of the patients are already refractory at that point.
Thank you, Dr. Hillengass, for taking the time to review this algorithm with us. We have covered a lot of material here, and we hope this discussion will reinforce the current standard of care practice for multiple myeloma in our community.
Thank you so much. It was a pleasure talking to you as always.